Acute coronary syndromes. Acute myocardial ischemia causes symptoms and signs referred to as acute coronary syndrome or ACS. ACS can be due to myocardial infarction with or without ST segment elevation on the electrocardiogram, or unstable angina, which is defined as prolonged angina at rest, new onset of angina with minimal provocation, or worsening of stable angina. ACS is responsible for almost 1.6 million hospitalizations annually in the United States. This presentation will discuss ACS due to non-ST elevation myocardial infarction and unstable angina. From the National Hospital Discharge Survey of 1999, the Center for Disease Control and Prevention, National Center for Health Statistics, data September 2000, it was reported that out of the 1.8 million hospital admissions with acute coronary syndrome, 1.42 million admissions per year were due to unstable angina or non-ST elevation MI, and almost 0.41 million admissions per year were due to ST segment elevation MIs. The pathogenesis of ACS most often involves fissuring and disruption of an atherosclerotic plaque in a coronary artery. This leads to platelet adhesion and activation, stimulating formation of an occluding thrombus. If the coronary artery is totally occluded, ST elevation infarction often occurs. Non-ST elevation myocardial infarction and unstable angina often result from a partially occlusive coronary thrombosis or distal microvascular thromboembolism from the plaque-associated thrombus. Coronary vasoconstriction or vasospasm may also play a role. This graphic depicts how plaque rupture and partially occlusive or totally occlusive thrombus may lead to myocardial ischemia and infarction. The clinical manifestation of coronary thrombosis depends on the extent and duration of thrombotic occlusion. Unstable angina and non-ST segment elevation MI are characterized by mural platelet-rich thrombi, which do not completely block coronary blood flow and therefore cause ischemia of relatively short duration. The aggregated platelets can serve as a substrate for further thrombus propagation, leading to formation of an occlusive red thrombus formed by entrapment of red blood cells within the fibrin mesh. This complete occlusion results in abrupt and persistent ischemia that clinically manifests as ST segment elevation MI. Left untreated, occlusion of the coronary arteries can lead to sudden cardiac death. The therapeutic goal in ST elevation myocardial infarction is to rapidly restore blood flow through the occluded coronary artery. This can be done with emergency interventions such as angioplasty and stenting, or with fibrinolytic drugs. In non-ST elevation MI, the diagnosis is supported by the presence of acute ST segment depression on ECG and or elevation of serum cardiac biomarkers. The goal in non-ST elevation MI is to prevent progression to complete coronary artery occlusion and to restore adequate blood flow to the ischemic myocardium. During the past 20 years, management of ACS has focused on rapid identification and treatment of patients with STEMI. However, it is now recognized that the same urgency should also be used for the management of patients with NSTEMI or unstable angina, because their morbidity and mortality rates are similar to those patients with STEMI. Thus, in modern practice, the goal is to rapidly identify and appropriately treat not only patients with STEMI who benefit from fibrinolytic therapy, but also high-risk NSTEMI patients who may benefit from ACC/AHA guidelines recommended management, including early GP2B3A inhibitors and early diagnostic catheterization. The study, published in 1991 by Wallenton, reports the risk of MI and death during treatment with low-dose aspirin and intravenous heparin in men with unstable coronary artery disease. It showed a risk ratio of almost 0.52 with a confidence interval of 0.37 to 0.72 in those patients who were started on aspirin during the course of their admission to the hospital and who were followed over a period of 12 months. In another study by Braunwald, published in Circulation in 2002, which compared unfractionated heparin and low molecular weight heparin, it was reported that low molecular weight heparin was better in the ASCENS and the TIMI 1b trial, with p-values reaching significance in both these studies as well. However, the other trials, which used dalteparin and nadraparin, did not show any improvement with using low molecular weight heparin. Clopidogrel provides a 20% relative risk reduction in the composite outcome of myocardial infarction, stroke, or cardiovascular death. Overall, there were 719 first events in the placebo group and 582 in the clopidogrel group. The hazard ratio curves begin to separate within the first few hours after therapy was instituted and continue to diverge over the remainder of the trial. Therefore, the recommendations are very strong for the use of antithrombotic therapy in most of the trials that were published in the late 90s and the early 2000s. Braunwald in 2002 reported strong evidence for immediate aspirin, clopidogrel if aspirin was contraindicated, aspirin and clopidogrel for up to 1 month if medical therapy or PCI is planned, heparin IV unfractionated or low molecular weight with antiplatelet agents, and enoxaparin preferred over unfractionated heparin unless CABG was planned within the first 24 hours. As regards the use of platelet glycoprotein 2b3A inhibitors, Braunwald also published his data and presented his evidence which showed use of GP2b3A inhibitors and aspirin heparin for all patients if catheterization or PCI was planned, use of eptifibatide or tirofiban or aspirin and heparin for high-risk patients in whom early catheterization PCI is not planned, and Class 2A evidence for use of GP2b3A inhibitor for patients already on aspirin, heparin, and clopidogrel if catheterization and PCI is planned. Or tirofiban, along with aspirin and heparin for patients. Use of eptifibatide or tirofiban, along with aspirin and heparin for patients without continuing ischemia in whom PCI is not planned, was Class 2B evidence, and abciximab for patients in whom PCI is not planned was reported as a Class 3 evidence. For anti-ischemic therapy, beta blockers, IV preferred to oral if not contraindicated, was a Class 1 evidence. Non-dihydropyridine calcium channel antagonists, if beta blockers contraindicated and no left ventricular dysfunction for recurrent ischemia, was also Class 1 evidence. And ACE inhibitor use if increased blood pressure persists with nitroglycerin, and beta blockers for patients with CHF or diabetes also had very strong evidence.